مستشفى الحرس الوطني وكذلك زملائي في المكتبات الطبية for sharing few cases. I will start the cases for now. For each case, I will just show the images first, and then I will show you the question with polling for 20 seconds. And then I will explain the images and then go for the final diagnosis. So I will start with the first case. So this case, 69-year-old lady with history of jaundice and generalized bone pain. Those are the images. I'll just allow you for like 15 seconds to have a look on the images, and then I'll show you the questions with the polling. So what's the most likely diagnosis for the cases? Either cholangiocarcinoma, metastasis, IgG4 disease, or none of above? I will end the polling just for after a few seconds. So no that significant difference between the choices from the participant. Majority choosing the have chose the cholangiocarcinoma. In our case, as we see here, that there is a soft tissue mass within the common bile duct with associated bile duct dilatation. There is no vascularity within this soft tissue mass, but we can notice that it is enhancing with avidity in the FDG. We found out this case was a metastasis from plasmacytoma. The plasmacytoma metastasis, the biliary system, is extremely rare, and we didn't have any. We didn't have a lot of information in the literature talking about the plasmacytoma metastasis. However, the liver is most commonly solid organ involved in the abdomen. The renal involvement is quite common for plasmacytoma metastasis as well. There are malignant and non-malignant causes of CBD thickening or soft tissue masses, cholangiocarcinoma, pancreatic adenocarcinoma, or metastasis, commonly from breast, lung, melanoma, or multiple myeloma as well. Non-malignant as pancreatitis, post-radiation, as cholangiopathy, parasitic, or primary sclerosing cholangitis. I'm showing to you this structured reporting form for the extrahepatic bile duct cancer, which is a consensus recommendation from the Korean Society in Abdominal Radiology. I'm sharing with you the article that I have initiated with this barcode. You can go directly for this article for further informations. I will move now for the second case. The second case is a 50-year-old lady with history of jaundice as well. Those are the acquired images. Kindly have a quiet look on those images. I will show you the multiple choices as well as the polling in just a few seconds. So those are the choices. This is the polling. It will be continued for 20 seconds. I will end the polling for after just a few seconds. Okay, I can see the majority of the participants had chosen the IgG4 disease and with a 41%, while 15% had chosen the cholangiocarcinoma, 26% choosing AIDS cholangiopathy. As you can see in the first image, that there's a main pancreatic duct dilatation. We can see here portal hepatis soft tissue mass, which is quite low in the T2 weighted images, with no significant arterial enhancement, no significant diffusion restriction. We found that this case had a very elevated level of the IgG4. The final diagnosis was an IgG4 with the suggestion that the serum IgG4 level more than 135 milligram per deciliter is supportive for diagnosis. The IgG4 diseases with involvement in intra-abdominal organs, it can appear as an autoimmune pancreatitis, sclerosing cholangitis, closing mesenteritis, cholecystitis, or IgG4 related renal disease, retroperitoneal fibrosis, inflammatory aortic aneurysm, prostatitis, or colorectal abnormalities as well. For our case, the IgG4 was quite elevated, and you can refer to this article, which is talking about the IgG4 related diseases from the head to toe. I will move now for the third case. The third case, that there is a 50-year-old with liver mass. I'll just show you 2 images, and then I will show you the polling and well as the multiple choices. So can you just have a look for 20 seconds, and then I will move for the choices. So those are the choices. I will show you the polling right now. I will just end the polling right now. So majority of you have chosen the right answer, which is lymphoproliferative disease as a part of the PTLD. So we can notice that there is a large hypodense liver lesion with partially seen paracaval lymphadenopathy. We can see here the atrophied left kidney. This is the coronal images, which is showing that already failed transplanted left kidney with minimal functioning. The left kidney seen in the iliac fossa. For the post-transplant lymphoproliferative disease, the risk factor are recognized, including the Epstein-Barr virus seronegativity at the time of the transplantation, concomitant cytomegalovirus virus infection, allograft type. Just the immunosuppressant regimen also affected the distribution of PTLD, as cyclosporin is quietly associated with the gastrointestinal tract and lymph node. You can refer to this article for further details about the post-transplant lymphoproliferative disease. Our case was biopsy proven as post-transplant lymphoproliferative disorder. I will move now for the fourth case. So we have a palpable mass and the digital rectal examination. Can you just please have a look for the next 15 or 10 seconds, and then I'll show you the multiple choices for what's the most likely diagnosis, and then I'll show you the polling. So can you please choose which is the most likely diagnosis? I will end the polling just in a few seconds. So what I can see there is a little bit predominance of the favoring diagnosis of gastrointestinal stromal tumor. Actually, our case is a little bit different, but it's more fibroangiomyoblastoma, which is a rare disorder involving the rectal and perineal region. You can see that the mass is isointense, T1 slightly lower signal intensity on T2 weighted images. We can notice that the mass is quite vascular in the periphery, which is suggestive more of the angiomyofibroblastoma, which is usually a painless mass with vascularization usually in the periphery. Our case was biopsy proven as angiomyofibroblastoma, and you can refer to this article for the tumor and tumor-like conditions of the anal canal and perianal regions with MRI findings. I will move now for the fifth case. So we have a 73-year-old male with palpable mass in digital rectal examination. I'm showing you this slide, and I have another slide for the abnormality. So I will show you the choices that we have for this case. So what do you think about this case? Is it a rectal adenocarcinoma? Is it a lymphoma? Is it a prostate cancer? Or none of above? I will end the polling just in a few seconds. So majority of the participants had chosen the lymphoma with 66%, while about 5% choosing the rectal adenocarcinoma, 15% had chosen the prostate cancer, 15% had chosen none of above. Actually, the biopsy result was surprising for each one saw this case previously. So we can notice that there is like a soft tissue mass arising from the lower part of the, or toward the apex of the prostate area, as we see here, which is extending to the anterior rectal wall. In the upper images, you can see that there is loss of the denonuclear fascia, which is indicating that there is loss of the fat plane between the rectum and the prostate. This case was biopsy proven prostate cancer invading the rectum. It is quite rare that we saw prostate cancer invasion to the rectum, as that the presence of rectoprostatic fascia, denonuclear fascia between the prostate and the anterior rectal wall, it's maintaining or preventing tumor extension to the rectum. Because of its related prostatic adenocarcinoma with rectal invasion can be misdiagnosed as rectal adenocarcinoma and colonoscopic biopsy specimen. Our colleague in histopathology have catched the invasion of the prostate cancer with Gelston score of 7. You can refer to this article, which is barely found in the literature about this. I'll move now for the sixth case. We have this patient with history of right seminoma post-resection in 2016 with the recent history of trauma to the inguinal region. I will show you the ultrasound first, and then I'll show you the MRI and CT images. So this is the ultrasound from the left testicle. So just to remind you that it is T2 fat sac. I will share now the multiple choices of the most likely diagnosis of our case. So what do you think about the diagnosis in the left testicle? I will just end the polling just in a few seconds. So a majority of the participants had chosen the lymphoma or leukemia as the main diagnosis. Second one was none of above. I don't know what they are thinking about, but 18% had chosen the atypical infection. No one had chosen the hematoma or rupture of the testicle. So in our case that we have, we are seeing that it is quite homogeneous and it is vascular mass in the testicle. In the ultrasound, it's confirming that it is quite vascular, no dominant mass could be seen, no calcification. This is the coronal images. We can see that the inferior extension of the spleen. So our case was splenogonadal fusion anomalies, which has two types, continuous and discontinuous type. Continuous type is gonadal linked to the spleen by trans or retroperitoneal cord of the splenic tissue or fibrous cords, with nodules of splenic tissues often associated with other congenital anomalies. The discontinuous form, which is an ectopicrest splenic tissues, are present in the gonads, with the splenogonadal fusion, with the ductus deferens or spermatic cord is exceedingly rare. You can refer to this article for the splenogonadal fusion, radiological and pathological correlation, review of the literature. This case from National Guard Hospital, which is suggestive, confirming that this is splenogonadal fusion anomalies. I'll move now for the last case. So we have 36-year-old male with testicular pain. I will show you the ultrasound first and then MRI images. So those are the testicular ultrasound. Those are the MRI images. I'll show you now the multiple choices and the polling. So can you please choose anyone? I'll just end the polling just in a few seconds. So I can see that the majority, with 63% had chosen the supernumerary testis, while 13% had chosen the seminoma, 3% had chosen the metastasis, 23% had chosen none of above. For this 36-year-old male, we can notice that from the first image that the both testicles are seen in the scrotal sacs in location. This image showing that it is in the distal area, distal inguinal region. We can see the central vascularity of this mass. It is quite similar to the normal signal intensity of the testicles, with also the diffusion weighted images as well as the T2 weighted images. This turned to be a synovial sarcoma, which is extremely rare tumor of the testis, as synovial sarcoma originate from the mesenchymal tissues. It is commonly present as a symptomatic slow-growing tumor and predominantly in the adolescent and young adult between 15 and 40 years. Usually, it is happening in the extremities at 60%. Few cases had been reported in the literature to be in the either inguinal or the testicular area or extra testicular areas. A massive tumor calcification, numerous intratumoral mast cells are associated with poorer prognosis. This is generally treated and considered as high-grade sarcoma. With age of older than 20 years, at diagnosis, the size of tumor, if it's more than 5 centimeters, and the undifferentiated subtype are the main prognostic factors. Our case was from the National Guard Hospital with it's a rare component of synovial sarcoma. You can refer to this article for the spectrum of extratesticular and testicular pathological condition at the scrotal MRI imaging. This was my last case, and thanks for everybody for participating and attending my presentation. Any questions?
يعطيك العافية أيمن. Excellent cases and very good combination. هل any questions أو مداخلة من الزملاء؟ ما في أي سؤال أو مداخلة. طبعا ال cases, as you can see, some are rare entities, and we are not a pathologist. We are not supposed to get the correct answer, but we have to be able to guide the treating team to the right management. So we have to recommend the appropriate management in terms of further imaging or surgical intervention. بعض الحالات تخدع زي الحالة synovial sarcoma of the scrotum is very rare, and it was deceiving. We were thinking it's an extra testicle, as most of the group here, but unfortunately it was a synovial sarcoma. Dalal al-Ahmadi. Yeah, Dalal is asking what's the clue of synovial sarcoma. There is no clue. It's we recommended surgical resection, and it was synovial sarcoma. Any other questions? I think we are on time.
Yes.
I would like, by the end of the session, to thank all the participants, and I would like also to thank our presenter today, Dr. Mahzari, for excellent presentation about pelvic MRI, and Ayeman for these nice cases. I would like to thank also my colleague in the organizing committee, Dr. Mut'ab al-Khair, Dr. Hana al-Faleh, and our scientific committee, as well as our partner GE and Ascend Company. وكل عام وانتم بخير. نراكم ان شاء الله بعد رمضان وبعد السمر، ونسأل الله سبحانه وتعالى أن يبلغنا وإياكم رمضان وأن يتقبل منا ومنكم صالح الأعمال. نراكم إن شاء الله على خير، وشكرا جزيلا.